This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and today my guest is Chasity Washington. Chasity is the director of the Center for Cancer Health Equity here at the James, a job and an issue that have always been vital and have become even more important in recent months as discussions on social justice and equality and inequality have taken center stage. The Black Lives Matter movement has gained a lot of well-deserved traction, and the COVID-19 pandemic has further exposed the inequality in our healthcare system. Welcome to the podcast, Chasity. I think we have a lot of important ground to cover today.
Yes, hi, and thank you for having me. This is, like you said, a timely topic, something that we in the center have been working on for a very long time, so I'm just glad to be here and to share today.
Well, let's start with an overview on racism and implicit bias, what they are, how they impact people and create a disparity in healthcare, and the urgent need for the Center for Cancer Health Equity that you lead. I mean, this is a huge topic that we could just talk on that alone for hours or days. But again, sort of tailor it a little bit toward the healthcare and in particular cancer. Right.
So I guess starting out with just a definition of racism in general. So this is overt, conscious bias, prejudice, discrimination that takes place when people have certain preconceived ideas about another group, gender, people's sexual orientation or gender identity. So those are sort of the purposeful feelings that someone has towards another group, whether true or false, often based on stereotypes or life experiences. And then within that, what's really important and what we're seeing a lot of protest about now is what's called systemic racism. So that's what's the policies, procedures, things that are in place that allow things such as police brutality and for things like, Breonna Taylor to not have justice for such a long period of time because of the processes and systems that are in place that don't allow that. And this systemic racism can lead to issues not only such as discrimination, but there's housing issues and redlining, and we can talk about that. And like you said, disparities in healthcare as well as education. And all of these things impact health and health disparities. They're called the social determinants of health. So education and all those things that are affected by this systemic racism then have a impact on what's going on within minority communities as far as health. And then we talk about implicit bias. And so these are the unconscious biases. So this is something where a person is not necessarily racist, but again, because of those experiences, because of things they've seen or heard throughout their lifetime, they might have what's called an unconscious bias. So this may be something, again, stereotypes in the back of their mind that in a situation, for instance, in healthcare, if you're in a high-paced setting with a patient, those things may come into play. So again, it's not something that you're consciously doing, but because of a time crunch or, if you're doing an interview and you pick a white person over a black person, not because you're consciously doing that, but subconsciously these implicit biases are what can cause issues in healthcare and other settings. So we talk about the IAT or Harvard Implicit Association test, and we like to encourage people to take those because then it will help you to identify these unconscious biases that people don't usually know that they have. And then we do at OSU offer some implicit bias training because once you identify those biases, you need to be able to give people skills to kind of mitigate those.
What is the name of that test again that people could take? And I'm guessing you can take it online?
Yes, it's online. And it's, again, if you Google Harvard IAT or Implicit Association test, it will come up. And it's been around for a really long time. You can take tests on religion, gender bias. You can take it on race. There's sexual orientation, gender identity. So there's a lot of different tests that you can take just to see if you have a bias in any of those areas.
I've been thinking a lot about this as I prepared to talk to you, and I think everyone, and when I say everyone, I literally mean everyone, has some sort of unconscious or implicit bias in them. And that's the society we grew up in. It's been part of our history from the beginning. But it seems like the important part is to take these tests, to think about it, to ask questions, to recognize that in yourself and become a better person. That I think that's what the last month or two, that's what I've been taking away from this last month. How can I learn more about my implicit bias, and what can I do to overcome it and be a more open, accepting person?
Correct. And I think there's a lot of that. We did some anti-racism discussions at the James in the last couple of weeks, and a lot of people were attending and sharing. But what I found most often was people wanted to know how they could help, how they could do better on an individual basis. They wanted things to read, and they wanted information on how they could, work on kind of microaggressions and things that they were doing, not only at work, but then also in their personal lives. So to me, I think that's one positive, at least from all of this that's going on, is that people are becoming aware and they want to do better and they want to learn more. So yeah, that is a perfect, I think, place to start. And I always tell people to be kind to yourself, because we are very egocentric, very ethnocentric. So you're going to have a bias most likely in one of the categories, if not multiple. And that, again, does not mean you're racist, doesn't mean that at all. It just means that we do have these unconscious thoughts and biases that can come into play. They may never come into play, but they could. So,
okay. Now, Ohio recently declared racism a public health issue. So now we're sort of getting closer to what you do. Mm-hmm. What does that mean? I know other states have and are doing the same thing. Declaring racism a health issue, how will that impact African Americans? How will it hopefully lead to better health care?
So, and I think what it's going to do is it's going to put it in the forefront. So there's a lot of people that have focused on health disparities in their work, but it's not been across the board. So what I've seen is now it's being put into policies. They're looking at practices and procedures. They're looking at a lot of the objectives and goals that we set, like Healthy People 2020. For cancer, we have a state cancer plan. So now that we're looking at racism as a public health issue, people are incorporating health equity goals in everything that they're doing now. So we're working on the state cancer plan right now, and we are making sure that every objective for every disease site, everything that we're doing, has some sort of health equity component to it, that we're looking at the disparities in lung cancer, breast cancer, and making sure that when we come up with our goals and objectives, that that's included. So I think that's going to be huge. Whereas, again, some of it was being done by different departments like ours in different areas. This is going to make it in the forefront and across the board. And also is starting to have people look outside of, again, clinical care, but what can we do partnering with education systems and housing and making sure that we're attacking everything from all sides, not just looking at the clinical care that the individuals receive. Yeah,
because I've heard that where you live, where you go to school, where you work, that impacts your health. Mm-hmm. And so it's not just healthcare. Everything's all part of a system that goes together, and you've got to improve the entire system.
Correct.
So that's a great background and an understanding of some of the issues that the Center for Cancer Health Equity deals with and has been dealing with. So walk us through some of the programs that you've been doing that address this disparity issue.
Right. So our center has been around since around 2003, and we look at, again, cancer health disparities. We look at the populations that are in Ohio. What are those cancers that they get more often? What are the barriers they have to care? Do they participate in clinical trials? How can we encourage them to participate if they don't? So we have several different program managers that focus on different communities. So we have bilingual staff that speak Spanish, Mandarin, Nepali, Somali, and then, of course, we have folks that reach out to African-American communities. And we've done things that focus on access, so helping them get in for cancer screenings, helping them to get their screenings and any follow-up care covered if they don't have insurance, linking them to insurance if they're eligible but just haven't been able to figure out the system. We provide navigation after a diagnosis, so that could be very costly. There's financial toxicity involved, so what can we do to connect them to resources that they may not know exist? And then we also offer free, Dr. Gray, our deputy director, offers free colonoscopies in the month of March. It's an effort with different people in the gastroenterology group. And so that's been really beneficial because there's not a lot around colonoscopy. There's a lot around breast. There's a program that, Susan G. Komen supports. There's the Breast and Cervical Cancer Project. So there's a lot of things for women that can help them offset those coverages. So that's one of the big things that the center has started itself. We're also looking into a mobile lung cancer screening unit. So we always talk a lot about Black-white disparities, but there's also a disparity in rural and Appalachian regions. Very few hospitals, very few access to clinics. So we are able to take mobile units down there and give those individuals access to screenings and care that they may not normally have access to. So we've done a lot of trying to address sort of the where and the barriers. So we're really good at that. And what we're trying to do now is kind of look at, well, what can we do to help support policy changes and those systemic things? And again, we had the anti-racism discussions within the James, but to look at, well, what can we do better as far as being a system that might have, some racist tendencies or policies? What can we do to look at those and fix those as well? So again, trying to look at it from all sides. We do have programming where we reach out to high school students. We work with the Metro High School here, and we have students come in and do disparities projects and research. And we also have a summer program in health disparities where we've had students come from Brigham Young University. We've worked with medical students here at OSU, and then we sponsor through Pelotonia dollars 6 students, 3 from Wilberforce and then 3 from Central State, so the historically Black colleges here in Ohio. And they get to learn resume building and how to do posters, and they get to do research, and they have a mentor within the Cancer Center. So really trying to, again, also promote the diversity in cancer and in healthcare, because, again, that's part of the problem, too. We don't have as many providers of color that we should.
One of the things I've heard from other doctors, Daryl Gray, who you mentioned, who's been on the podcast, and I've been to that clinic where they do the screening colonoscopies, is that African Americans, particularly African American men, have a higher incident rate of certain kinds of cancer, such as colon cancer, and a higher death rate than the general population. And there's other minority groups as well. And it seems that also what you said about rural Appalachia and poverty and racism seem to go together and create geographical locations where there's just not the healthcare access, there's not the screening access. People don't have healthcare. They don't have primary care physicians. So it's all that ties together and leads to later diagnoses and poorer results.
Right. So, and I think it's the Black-white disparity is the biggest, but we're starting to see disparities in other groups. And I think, again, what race is a social construct. Race isn't really real. There's one race, the human race, but race matters, right? We make people fill out their race when we're doing research, and we make them fill out race on everything. And we look at disparities by race, but we also tend to do a disservice in some groups because, again, we're research-minded, and if there's not enough people for it to be statistically significant, we roll them all up together. So, for instance, when you start looking at Hispanics and certain Asian populations, we roll everything up. We don't look at Mexicans versus Puerto Ricans or Filipinos versus, the Hmong community. And when you start looking within those subgroups, there's even more disparities. So we're learning that maybe we need to de-aggregate data and look at different individuals by their countries of origin, because you could then have disparities within those groups that we're missing because we're rolling them up into one large group. So we're starting to encourage people to do some of that as well. We're trying to capture people by country of origin, not just saying, are you Hispanic, yes or no? And so that we can sort of really look at, well, what are those issues within those populations, and what can we do to help with, barriers or access issues? And if there's cultural things that we can look at and support, what are those? And really trying to, again, address the issues for those groups individually.
Okay, we're going to take a quick break, and when we come back, Chasity and I were going to talk about COVID-19 and how that has shown a spotlight on healthcare disparity and some of the things that the James and Ohio State are doing to help people.
A revolution in lung cancer treatment is happening at the James. We're proving lung cancer isn't solely defined by location and stage, but rather the individual molecules and genes that drive it. Simply put, there is no routine lung cancer. That's why our world-renowned specialists put their expertise towards treating one particular lung cancer, yours. At the James, we go beyond the routine to prevent, detect, treat, and cure your lung cancer. To learn more, call 1-800-293-5066.
We're back with Chasity Washington, the director of the Center for Cancer Health Equity here at the James. And now we're going to talk about COVID-19. And this is obviously the most important healthcare issue going on right now. So, Chasity, how does it impact underserved and minority populations?
Right. So I think the COVID-19 pandemic has shown folks in real time that these disparities exist in these communities. We say all the time, this population has a higher incidence rate of cancer or heart disease. And it doesn't really mean a lot because you're not seeing people, die. You're not seeing the daily counts and the things that we're seeing in the pandemic. But it's essentially the same issues, right? So we said place matters. So where you live matters. And it stems back to, again, the systemic racism and redlining and where people were allowed to live. But so then public transportation, a lot of these individuals, have to use public transportation. So they're in close proximities. They have essential jobs, and they can't work from home. So again, they're going out, they're being exposed potentially to COVID-19. They may not live in a house where they can social distance, if someone does get COVID and it tests positive. They may live in multi-generational households, again, so multiple people in one dwelling. So social distancing is not as easily done in those populations. Access to testing. So, where were the testing sites when this all first started? I mean, we have more pop-up testing and more testing with Columbus Public Health. But again, if you can't get to those testing locations or they're not in a location near you or you can't drive through because you don't have a vehicle, those are also disparities that these people are experiencing. And so if you don't know if you have it, you don't know to quarantine or isolate. And it impacts more and more and more back on those social determinants of health in those communities.
It seems like in any sort of national crisis, a recession, a depression, a healthcare crisis, that poor people are always going to be impacted more because they have less resources and the resources run out quicker.
Correct. I mean, and if you've seen anything in the news about the cost of, even food, right? So if you're already in a low-income area, you're already, having issues with food security, the price of food now is just going to impact that even more, so that affects your health. And then we saw this with the kids. We had them all go to virtual online learning, but not everybody had the internet access. Not everybody had the Chromebooks or the laptops to do that. So we did a lot of that. So once the pandemic hit, we switched some of our focus from cancer to sort of helping those populations with COVID resources. So we were connecting them to some of the internet providers had free 90-day internet services. So we were helping people connect to that, helping the businesses with the loans that they were allowed to get. They were difficult to fill out the paperwork. So we had people helping them fill out the paperwork in the Somali community for Somali businesses. So again, those sorts of barriers, if you're not familiar with that and those processes, even when there are resources, you can't easily always access those.
Yeah, especially if you have English is not your first language.
Correct.
It's intimidating if it is filling out forms, and if you can't do it online, that makes it harder. So there's just so many obstacles and hurdles that people in the lower socioeconomic levels have to deal with, and that's where you come in. Right.
So, and I think it was great that we were allowed to switch during the pandemic time and do some of that. We did translations of information on how to wear masks, and we did some videos, and we worked with our interpreter services here and made us a website for people who were tech savvy that could go and find different resources in different languages that they could then share within those communities. And again, we did some, like I said, Facebook videos on how to wear a mask and how to social distance, and providing resources of where the pantries are, where you could go to get all these different things. And so I think, again, being able to do those things as a center is rewarding, especially, now in this global pandemic time where all of these things are even more urgent in these communities.
Now, you've mentioned the term redlining a couple times,
Yes.
and I think I know what that is and how it applies to real estate and the purchase of homes. But explain what it is and how that has led to segregations and the creation of just lower class neighborhoods.
So redlining is historically how it's tied back to how some of the home ownership loans were given, and there were ratings from A to D in the property that people were able to get. So A was sort of the best property and the best neighborhoods, and then D was the lower or worse locations, usually around industry. Highways would go, run through those neighborhoods. They might be near manufacturing, and that's a lot of where, if they were allowed to get home ownership loans, a lot of people of color were then given residence in those areas.
In the D areas.
In the D areas.
And they couldn't get mortgages in the A areas.
Correct.
So that was basically segregating them out of the nicer neighborhoods and school systems.
Right. And so this is, like, I think in the 1930s, and we're still seeing that today. So the Kirwan Institute here does a really good job and has a lot of presentations on these sorts of topics. And they have shared a map that shows pretty much what it was like then and what it's like now. And there's really been no change in the racial and ethnic breakdown of people who live in the A, the B, the C, and the D. A little bit of movement between the B and the C, but again, most people of color, most Hispanics, Latinos, African Americans live in these C and D neighborhoods. And then if you go and add, infant mortality data, cancer disparities, the COVID-19 pandemic disparities, if you overlay all of those maps, incidence, mortality rates, you're going to see that a lot of them are in those areas where that redlining took place. So again, we say place matters, right? So they're going to be a place with a higher rate of African American incarceration. All of those things, not exact overlays, but there are certain zip codes that, again, absorb the brunt of these health disparities. And you can trace a lot of that back to that original redlining over 70-some years ago.
See, I think understanding this is one of the steps towards changing this. And so that's why it's important for you and others to tell this history, to tell how it's impacted what's going on today and will continue to go on, and even more so, how we can change it and how we must change it in order to have a fair and equitable society.
Right. And like I said, it's resources too. Some of those neighborhoods, you have no grocery stores or no grocery stores that...
Food deserts.
Yep, food deserts that they can walk to, or even if you catch a bus, like, can you imagine, I don't know how many groceries you buy. I have 2 boys at home. I can imagine bringing that amount of groceries home on a bus or trying to walk, to get that amount of food.
There's 2 grocery stores within a mile of my house in Clintonville.
Right.
And
so that's not always the case. And then, we've heard things about women who, have WIC for their children and need to go get milk, and they can't get it because there's no grocery store. And then the convenience stores won't accept WIC because there's a policy or something where if they don't have a certain number of or amount of milk product on their shelves, they get fined. So therefore, they don't want to accept WIC because then all the women will come in and buy those and they'll get penalized. So like I said, that's a policy thing. That's something that we could look at and change. Why do they need to be penalized if they don't have milk on their shelves? And
what is WIC?
Women, Infant, and Children program through the state.
And it provides.
Yeah. So women who fit certain income guidelines and have children can get things like formula. And so it's an assistance program. And so, again, you have women in these zip codes that are on this program but then can't get access to the things, that the service provides.
So I think everyone listening can tell about your passion for this, your motivation. But where does that come from? When did you, in your career, decide that this is what I want to do, this is who I want to help?
So I've always wanted to do something in health. I wasn't sure what it was. I bounced around. So maybe I'll be a physician, maybe I'll be a nurse. But then when I was at Ohio State, someone talked to me about public health and all the things that it involved. And it kind of just made sense because I would rather not see people get sick than to treat them. I'd rather do things to intervene and make their health a priority and make things better. And then, again, looking at my own family, we have histories of heart disease, diabetes, we had pancreatic cancer. And again, knowing that those disparities exist in my community, what could I do to help, people that look like me, people who come from places like me? My family is from Brown County, Ohio. So not necessarily Appalachia, but it's a rural setting on the Ohio River. So again, what could I do to give back and sort of help with those disparities? And then one of my first jobs out of college was with the American Cancer Society, and I got to meet a wonderful group of women that were working with African American health disparities. And then after that, that was it. I was just, this is what I need to do. This is where I need to be. The opportunity came with the James to be in this center, that's what they're focusing on. That's what they're doing. And I jumped on that opportunity and have been here since December 2002 and wouldn't change a thing.
So the Center for Cancer Health Equity here, how rare is that at a cancer center? And maybe even historically, it's been around close to 20 years. How new was that when it was formed?
So yeah, when we started, it was pretty new. So
in terms of nationally?
Yeah, so we're a comprehensive cancer center, and part of what we're measured on is outreach and education and diversity and inclusion in our center. But that's really grown. So that was the onus for creating the department way back then, but there weren't very many centers like ours. And they're starting to grow now because the Cancer Center has made that a priority, or the National Cancer Institute has made that a priority. But we were sort of ahead of the game. So, I applaud the leadership of the James for creating this department and allowing it to grow and funding it. They put money behind it, and that's huge. A lot of these departments that are starting to form in these cancer centers, they may have one or two staff, and they rely heavily on grant funds. And we've been blessed and fortunate to actually have money to support our staff and grow. And so again, it's fairly new that other people are starting to have these centers, but I will say that we were sort of ahead of the game. And Dr. Pasquette is really well known for community outreach and engagement. So we also have a lot of centers that contact us and reach out to us, how do you do it? And so that's also been, I think, part of my passion and pride in being a part of such a wonderful center.
What gives you optimism in this? Things have been at least being talked about more recently in the past 4, 5, 6 months. But what gives you optimism that we are headed in the right direction, that we are going to really focus on social justice, on equality? What do you see happening?
I think if you just watch the protest on TV and see the different races and ages and everyone coming together, I think the fact that we've made public racism a public health issue, I think that's huge. I think all the discussions and dialogues, like I said, people that I've talked to, we're busier than ever now as the center. Like, people are coming to us, what can we do? How do we fix this? We've got recently in the past year, we've actually hired a program manager that looks at LGBTQ issues. So we've had people coming to us, asking about how they can collect that information on their patients at registration, so they even know if they have that population that they're serving and what are those issues. How do we do implicit bias training? How do we, educate our staff? How do we look at being mentors outside of these walls? We want to increase the diversity in nursing. We want to, what can we do? So I think that has given me hope. It's also given us a lot of work, but so it's job security, right? So I think that is what is keeping me cautiously optimistic. It could all fade eventually, but I think this is the longest I've seen ongoing movement, ongoing discussion, and progress around these issues. So, like I said, I'm hopeful, and I know we'll keep doing what we need to do in keeping the message out there and keeping the dialogue going. So,
well, good. Keep that dialogue going because that's important. And thanks for sharing it with us and telling us all about the great and important work that you and your center do.
Well, thank you. Thank you for having me.
So, Chasity, if anyone listening has been inspired by you and believes in what you and the center are doing and wants to get involved, how can they contact you and get involved?
So they can email me directly, and I will say this slowly. It's CHASITY.WASHINGTON@OSUMC.edu, and I will respond, connect them to the right person, and get them involved in any way that they're interested. We're always looking forward for people to help.
Okay, thank you. And thank you for sharing all the great work you and the center do and keeping the dialogue going. This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.